We're now doing our buzzer round. This is going to be a bit different. I'm going to explain the rules to you right now. They're actually relatively simple. As you can see, you have a buzzer on your table. There is an initial question, which is essentially a right or wrong answer or a black and white answer. You know, what's the square root of 4? The answer, someone is, what is the square root of 4? 2. You've got the buzzer has to go off.
Oh, wow.
So it was first here, and the answer is 2. So 2. And under those circumstances, then, you get control of the next question. And then there are a series of questions that come from there. And then once we've completed that, you can score up to about 6 marks on each individual question. And then we go back to another buzzer round. And so it's possible, if you don't get any buzzer round questions right, you don't get any points at all.
Any negative points?
There are no negative points unless Dave McDermott's playing, in which case they originally have -3 before we start. Are we good to go? So are we all clear?
2 rounds or 1 round?
No, there are about 6 questions.
Okay,
So 6 buzzer questions, and the issue here is, before we start, I'd like to introduce the 2 captains. I'm going to start with Tanya. Tanya, would you like to introduce yourself and maybe your team?
Hi, I'm Tanya Dorff. I'm the section chief for genitourinary medical oncology at City of Hope in Southern California. And I'm pleased to have with me my friend and colleague, Monty Pal, also from City of Hope, and Petros Grivas from University of Washington, Seattle Cancer Center.
Tony, you've got the wrong hat on.
No. To understand, this is mind games. So this is an Iowa hat. So Toni Choueiri from Boston, Dana-Farber. I lead the GU program. Very pleased to have my good friend Jonathan Rosenberg from Memorial Sloan Kettering Cancer Center in New York, the second best town in sports. And my good friend Rana McKay from UCSD, where she leads the GU program.
Fabulous. We're going to start with the first buzzer question. So what is the design of the prostate cancer trial called PEACE-1 out of France? Oh, so, it was Tanya. Was it Tanya? It was Tanya. Yes. Oh, you're far away. Rana. I apologize. Rana. Far away. I apologize.
PEACE-1 was a 2-stage design. It was a multifactorial 2-stage design of basically looking at ADT plus minus abiraterone, and then the standard of care arm got changed to add docetaxel, but also looking at the contribution of radiation as well.
Yes. I think it's good enough. Good enough.
Yes.
Yeah, that deserves a round of applause. There we are. The question, okay, so here we are. What did the radiotherapy subset of PEACE-1 show? You don't need a buzzer. You've got the control of this question. So, yes, you've got control.
The subset demonstrated that in the abiraterone-treated patients, there was a benefit to the addition of radiotherapy, but in the patients who were not receiving abiraterone, there was no benefit.
And why would that be the case?
We don't really actually know, because that's opposite of what we saw in Stampede, where the radiation got better.
Here we go. Here is the Stampede trial.
Yes, this is opposite. We saw the opposite of that effect, because in Stampede, there was a benefit to addition of radiation only in the low-risk population.
And so here is the Stampede data that we showed before. So how do you explain, so this is frontline disease. It's essentially low-risk, low volume disease, and it's the addition of radiation therapy. You've got 2 big randomized trials, one from France, one from the UK. The UK one's almost certainly better. That's a joke. And because Kroon study is fabulous. Why would you get one study that only showing working with abiraterone, and the other study showing that actually it works across the board? What would be an possible explanation for those findings? And your whole team can answer, by the way. It doesn't have to be...
Volume of disease on the context of that study.
Yes.
Basically, how aggressive was their disease up front?
Yes.
I think is probably, volume of disease probably explains some portion of that.
Okay, so I think I've spoken to Kareem about this.
Okay.
Can I just
Tanya, would you like to buzz in? Yes, of course. I think it's fair. I think this is a modification to the rules at the last moment. I think it's fair for the other team to buzz in and see if they can add something and get some points. Is that right? Is that reasonable?
I think it's a very reasonable approach.
We're going to make it up as we go along a little bit, if I may. Okay, far away.
I think if you look at the neoadjuvant studies, the addition of the stronger systemic therapy actually impacts how much cancer is eliminated in the primary gland, and so it maybe takes the place of some of what the radiotherapy was intending to do.
Okay. And I spoke to Karim around this, and I've spoken to Nick James, who lead Piece 1 in Stampede. Nick feels that his trial, because Stampede was much, much larger, was more robust, and this finding might have just been a finding which is an unusual finding as part of statistical noise. Karim feels that there were some differences in the way the disease, the endpoints of the trial were assessed, and some subtle differences between the methodology and the bone scanning, which may have accounted for the differences. I don't think anyone's really explained it particularly well.
And it's only a PFS benefit, not an OS benefit like was seen in Stampede. So it's very kind of wishy-washy.
And also quality of life benefit, right? Preventing obstructive uropathy.
Yeah.
Yeah, but we win.
We're going to go 5 points. We're going to go 5 points here and 2 points here, if we can. Now we're moving to the next question, if we can.
Okay.
5 and 2 would be great. Okay, so here we are. What's the name of the renal cancer trial named after a star sign, a zodiac star sign?
Calypso.
A renal cancer trial named after a star
zodiac sign.
Zodiac sign. Calypso's not a dancer.
This ancient Greek mythology. Don't mix up. Ancient Greek mythology.
Renal cancer trial after a star sign.
Zodiac. Like cancer.
Okay, I'm gonna go to the other side.
You know what are like? No. The zodiac sign, like like Leo.
Taurus, not Taurus, before Taurus. Taurus is the TiVo.
Yes.
Before Taurus, the Sut and Pazzo back
Yes,
and forth.
it's right. That's what it's called.
No, the Sut and
It's called
Pazzo before.
It's got the letter P.
Pisces.
Pisces.
Yes.
Pisces. Oh, God.
Great. Okay.
Oh, God.
I can't believe it.
Yeah.
Okay, so here you have 2 different drugs in pre-treated clear cell renal cancer. These are the Kaplan-Meier curves, but the names of the drugs have been removed to protect the innocent. What is the drug on the left, and what is the drug on the right? You don't have to press the buzzer, Tony. It's your question. It belongs to you.
Belzutifan.
Which one's belzutifan?
21%.
So belzutifan on the left. What's the drug on the right?
So belzutifan and so 2 different trials.
2 different trials, 2 different drugs. The left hand.
TiVo.
Tivozanib.
Yes.
Yeah,
Well, you can't buzz in.
That was
Okay.
Belzutifan 21%, TiVo 18.
So you've got that right. Okay, so you've got both of those right. They look quite similar, don't they?
They do.
What do you think about the fact they look so similar?
Different population, one, that's it. And
So here we go. What are the differences in design of the trial? And why do they look so similar?
You know, one is more advanced, certainly post-PD-1 VEGF.
Which one's
very
that?
few patients. That's the 005 like.
Belzutifan. So let's say belzutifan and TiVo.
3rd and 4th line. The other one is mostly 2nd and some 3rd line. The control arm is also different, and prior PD-1 is also different. Every patient had prior PD-1, that's the belzutifan, and the other one, 60-70%, not everyone.
And are the drugs therefore interchangeable in the 3rd line setting, or is there a preference for one drug versus the other?
No, they're not interchangeable.
Why are they not interchangeable? They look so similar, Tony.
Well, because I said so.
Okay, that's not going to score a huge number of marks. Do you think the data on one of those drugs is better than another?
I think they're different setting. I think, I think durability, belzutifan,
quality of life is better, different side effect profile.
You're on 4 points so far. We're going to come across the other team in a second. This is a study called T-Nevo. No, hold on a minute. We're no buzzing. I'm going to say I will say when we buzz. Can we agree on that at least? Okay, so here we go. What's the difference between Contact 3 and T-Nevo? Contact 3 was the trial, well, you know what it is, Tony, far away.
It's T-Nevo 2, actually, right?
T-Nevo 2.
So Contact 3, the control arm is Cabo, and the addition is the PD-L1 inhibitor atezolizumab. And with T-Nivo2, the control, the TKI is Tivo, and the addition is the PD-1 inhibitor nivolumab. They're all post-PD-1, PD-L1 inhibitor.
And what are the chances of this trial being positive, do you think? And what are the concerns you have around this trial, if there are any? What are the increased chances of it being positive, and what are the challenges associated with the trial design?
Well, I think the trial, one of the issues here is that with 326 patients, you need a large delta. So it doesn't mean it will not happen. It's smaller than CONTACT-3, which was Monty 550. So that is the issue. But on the other hand, it's pure clear cell renal cell cancer. So I can't play the chances. After all the result of the studies, positive, negative, I'm going to plead the fifth.
Monty, do you want to, or your team, Tanya, sorry, I apologize, your team want to come in and speculate why this may or may not be positive and build on what Tony said to win some points?
I think the dosing really throws a wrench into this, right? That modification that we had early on in this trial to drop the TiVo dose, it certainly challenges the primary endpoint in the study. So I'm going to go out on a limb and say, I'd be surprised if it turns out to be positive.
The other difference is, and you can correct me if I'm wrong, but I think the CONTACT-03, Tony, mandated that the IO was the immediately prior line of therapy, while in T-Nivo2, this is not the case. So you may have prior IO late, further beyond in the past. That may potentially have an impact on the result, but I agree, it would be surprised if it's positive.
That is true, but I think the bottom line will end up with a vast majority of patients where IO is just the line of therapy before. So while this is true, it may not hold.
Depending on what the sequence
is. And I'm intrigued to know what a PD-1 inhibitor does, especially with all the differences between PD-1, PD-L1 in metastatic and now in adjuvant renal cell.
With always benefit on Keynote 564, recently announced.
Let's hope Tom doesn't have a question about 564.
Let's hope not. So we're going to get 5 questions, but I think it was a really good comeback. Okay. So we're going for 3, 5 versus 3. Okay, now
wait, are we both?
I thought they did quite well.
5 or us.
They did well. It was a good appeal.
So it's 10-5.
Well, I don't know. I haven't seen the score yet.
In the first round, we got 5, and they got.
No, we've got to increase. So so is it 10-5 right now?
I believe it.
10-5.
Great.
Yeah.
Okay, so we're 10-5.
Hey, come on.
We're now going to a buzz-around question. Are we ready?
Yeah.
Name a god in Norse mythology associated with a bladder cancer trial.
Bladder cancer.
Thor.
What is the right answer? Is the right answer?
Are you sure the buzzer
Hold
was
on, watching Marvel.
Wait, were you first?
She wants to say Zeus.
That's right. Oh, is that how it works? Could you help me in the audience? Perhaps point to who was first. I got the impression that they were first. They were first, weren't they? Tanya was first.
Okay.
Oh, no, that makes it complicated.
So
okay.
We'll have to get the buzzer right.
It's okay, you guys go.
Did you know the answer to that question?
Yes.
Yes, okay, great. I apologize. Okay, here we go. In Thor, which hazard ratios for PNS and OS were statistically significant and which were greater than 1, and how can this be explained? And while you're thinking about that, I'm just going to explain to the audience this trial. There were 2 cohorts in this trial. Cohort 1, they're both, by the way, erdafitinib versus something, and they're both in patients with FGFR alterations. Cohort 1 compared it with chemotherapy, and cohort 2 compared with pembrolizumab. And they had quite divergent results, although many of us felt they get similar results. Do you want to describe the results of the trial?
So I can take a quick stab on it. So cohort 1, erdafitinib versus taxane in US and in Europe, selected population, FGFR2 or 3 mutation or fusion, clear overall survival benefit, hazard ratio 0.64, favoring erda. I think this consolidates erda as a great option for patients with this biomarker. It's about 20% of patients, about 15% or so in bladder cancer, 30% in upper tract disease. And I think it definitely makes it a question which is the optimal sequence. I think it's a great option post-IO. In cohort 2, though, that answers your question. In the PFS and OS, actually were not significantly different, and the hazard ratio was actually more than 1. And I think it can be explained by the tail of the curve on pembro. So erdafitinib had a 40% response rate, 22% response rate with pembro. So you need a response right away. I would go with erda. But the curves cross, and you see a tail of the curve. These 22% of patients who respond to pembro, many had durable responses. So that tail of the curve kind of negates the response benefit with ERDA, and you get with no overall survival benefit and no PFS benefit at the end of the day.
So here are the results which you describe. You're absolutely right, Petros. These I thought were surprising. Have you got any biological explanation why pembrolizumab should be working so well in patients with FGFR alterations, in the knowledge that the PD-L1 positivity rate is so low in those patients with FGFR alterations?
There's a huge debate, and I know Matt Galsky is sitting over there.
He can't answer the question.
I
He's
know,
not
no.
allowed to.
Well, I can cite his paper. Yeah. So Wang, right, was the first author, I think, in that paper. They looked at tumor T-cell infiltration in the tumor tissue and of lymphocytes, and also immunosuppressive signal in the stroma. And in FGFR3 mutated tumors, you see less T-cell infiltration, but less immunosuppression in the stroma, kind of, counteracting each other. So their conclusion was that the response rate is probably comparable in FGFR mutated and wild-type patients.
Okay, and this is the next question, which I think is a tricky one. How does the biology of upper tract urothelial cancer and bladder cancer differ? And how do you explain the results of Thor in the upper tract cohort? Because when ERDA was versus chemotherapy, in the upper tract cohort, it worked incredibly well. But when you compared it with pembrolizumab, with upper tract disease, and by the way, in subsets of the Adjuvant trials, it looked like immune therapy didn't work well in upper tract disease. Suddenly, that pembrolizumab is performing at least as well. These results seem crazy to me. How do you explain this?
There's data published by Faltas et al. In Cornell, and Jonathan, you know the data, that look at the T-cell infiltration, also the molecular subtype. And what Bissoy published was that you have more cold tumors, or luminal subtype, molecular subtype in the upper tract disease, and that may explain less impact, less effectiveness of checkpoint inhibition, and also higher influence, frequency of FGFR3 alterations. In the trial that Monty, you led, which is the infigratinib versus placebo adjuvant trial, the Proof 302, we saw 30% frequency of FGFR3 alterations in upper tract, only 13% in bladder. So I think upper tract is enriched in a molecular subtype that is more responsive to FGFR biology and less responsive to IO in the upper tract.
Fabulous. This is a tricky question. How do you explain the biology of this disease here? And what's the biology of upper tract disease compared to normal disease?
I think it's not a different tumor type. I think what we see in bladder and upper tract is probably an overlapping of biology, but you have an overrepresentation of the luminal subtype in the upper tract disease. Right. So higher FGFR3 alteration, GATA3, FOXA1, and more luminal subtype, less T-cell infiltration there.
Jonathan, Tony, Rana, do you want to add anything to this Thor and this erdafitinib and this upper tract debate? And maybe just talk a bit about in which patients you think erdafitinib is a clear standard of care.
So going back just for a second to what we were just talking about, don't overinterpret the data in the upper tract, particularly versus pembrolizumab. The confidence interval crosses 1, small subset of patients. So I don't know that it is worse. It just may not, none of them benefited particularly from erdafitinib compared to pembrolizumab. And so I'm not sure upper tract was any different. I think I may have lost my mic for a minute. So I think the biology, there are differences in biology. Embryologically, upper tract is derived from different tissue. And I don't think we've fully understood that and how it impacts things. And I think some of it probably comes down to infiltration levels in different tumors, but I wouldn't overinterpret subsets.
It's underpowered. That's a good point.
So overinterpret. So we're going to go for 4 points here and 2 points here. Is that fair?
Why not 5?
Oh, we're going to go for 4 this time. 4 this time. I think that's
the
fair.
moderator is biased.
Okay. So we're 12-9, I believe.
We're paying him.
So the next question. There was an original cancer immunity cycle. That was the cycle that...
Wait until he gets the question out.
Ira? That one?
No.
Read the
The
question.
original.
Well, you've buzzed. You can't buzz early.
You cannot buzz early.
Okay.
We have to finish the question.
So
We can answer.
moving forwards, if you buzz, and then it goes to the other team if you get it wrong.
But when is early?
Well, you buzzed, but I'm going to ask you now, and you said the wrong. Okay, we're going to go. Okay. So we're going to start again if we may. But if you answer it, then you have to answer it. Otherwise, it goes to the other team. Okay. So with this cancer immunity cycle,
Are we re-buzzing?
Yes, we are rebuzzing. What was the name of the first author on the paper in Cell?
Wasn't it Ira?
No, he was senior.
What was it? When did you buzz?
Van Dijk, the Netherlands from Netherlands.
No.
Miguel was the fan.
Dan Chen.
There were 2 papers, actually.
Dan Chen.
Dan Chen.
It's definitely Dan Chen.
The cancer
It's Dan Chen. It's Dan Chen.
Pretty sure it's, yeah.
Okay, so
we'll contest it.
there will be a contestant. I'm up for that.
10
So
points.
there's been a modification to this cycle, and that modification came out about a month ago. What was that modification? Why is it relevant? And then which phenotypes does bladder, renal, and prostate cancer fall into? It's your question, Tony. You got it right. You're good to go.
What was added was the tumor microenvironment,
Right.
and Tom Powell's is an author.
Well, that wasn't the bit that I was looking for, but the tumor microenvironment is one part of it. And do you know the detail of the tumor microenvironment and the components of that were relevant?
I mean, the different type of immune cells in the microenvironment, the M1, M2 macrophage,
Yes,
Treg,
tertiary lymphoid structures.
Treg,
Yeah.
and others.
So essentially, it looks like there can be T-cell trafficking taking place somewhat independently, not completely, but somewhat independently within the tumor itself, and tertiary lymphoid structures
TLS.
have a really important role to play in that. And what about the immune phenotypes? We have deserts, we have excluded, and we have infiltrated. And I know, Jonathan, you did a lot of work on this. Which is bladder, which is renal, and which is prostate?
I mean, bladder has multiple phenotypes, right? I mean,
But which is the predominant one in Sanj's original paper, which I think you were...
Infiltrated, inflamed.
People talk about it being
basal
excluded.
squamous, right?
And what about prostate cancer?
The desert.
Desert.
Welcome
Desert,
to the
excellent.
desert.
And kidney cancer?
So renal infiltrated,
Yes.
bladder excluded, and prostate there is nothing. Desert. That's
Okay.
the majority. I
So,
think.
this is now a new frontline cancer trial in renal cancer.
What's that?
It's axitinib versus axitinib PD-1 LAG3, axitinib PD-1 LAG3 TIGIT, or axipembro as the control arm. What is the design of this trial? How important is it? And how does TIGIT and LAG3 work? These are 2 new drugs that we're beginning to use, both of which are exciting, 2 of the most exciting targets. Far away. You don't have to buzz, Tony. It's your question. Well, I take your point.
So, I mean, control arm, Axi, and Pembro, obviously that's an acceptable control arm. And then on each, you're going to add either SLAG3 or TIGIT. So it's reasonable, playing with all the tumor microenvironment and pairing it with a PD-1 inhibitor as the single agent activity, at least from other tumors, and very little from renal data is negative. So it's reasonable. I believe it's a randomized phase 2 dose-finding activity, so it's reasonable.
It's 1 checkpoint, 2 checkpoint, 3 checkpoint, right?
And a TKI.
Right, plus a TKI. So.
And do you want to speculate on how TIGIT and LAG3 work as immune checkpoints?
In kidney cancer.
Does this team want to take that over?
Kidney cancer.
Yeah, well, TIGIT is found on T cells and NK cells. LAG3 plays a role in T cells activating B cells, from what I understand. So, very complex effect on the immune milieu.
So both expressed on T cells, both immune checkpoints, one associated with natural killer cells, TIGIT, LAG3, MHC class 2, and building on top of PD-L1 therapy. Okay.
And there's a phase 3 trial completely separate to melanoma, where Nivo, I think, plus LAG3, latilimab has indication. So hard to extrapolate from different tumor types.
Don't you think another arm of the PD-1 plus the TIGIT alone, why are we adding, is not reasonable? Why adding the SLAG3 always on top?
And do we think that's a better drug than TIGIT in kidney cancer? Is there any data? Okay, this will be a bonus question for both teams. Is there any data on LAG3 or TIGIT in kidney cancer?
Yes.
Oh, I don't know it. That's fine. Okay, it's far away.
Yeah,
Go for it.
From fraction?
but
The question, is it in the public domain?
I don't think
remember.
it's in public domain.
Yeah.
Yeah, from fraction.
Yeah,
RCC,
from
right?
fraction.
From
Yeah,
fraction.
I think
yeah.
it is, but it's not. You know what I mean? Like
Okay, so we're going to move on before we get ourselves into a lot of trouble. Okay, so here we go. We've got another question, another buzz around question, if we can.
Buzzer. Buzzer.
Oh, points. I apologise. I think 3. Oh no, I think 4 points and...
One.
One?
One for them?
Or two, 4 and 2. 4 and 2 I
Four
think
and
is
two?
fair.
Okay.
I think that's fair.
Okay.
I think I might have to be a bit more mechanical in my points in the next round, but there we
Okay.
go. Okay, so which event happened first? The moon landings or the discovery of cisplatin?
Moon landing was 1967, right?
Yeah.
69.
69.
69.
Tell them, Tom.
And cisplatin was afterwards, right? Or before.
Well, you buzzed now. So you
Before,
better
before.
answer it.
Cisplatin.
Before. So,
Cisplatin was first discovered in 1965 by a guy called Rosenberg.
Rosenberg,
Okay.
Not relation.
That's his dad.
Okay, so
A lot of Rosenbergs in cancer.
so here we go. Here we go. This is in each round we're going to have an ESMO update. So this
We
is
got the point, right?
no, you get no points for the first question. You just own the question.
Okay.
So these are interim results from a phase 1 study looking at AMG 509 in metastatic castrate-resistant prostate cancer. Tanya, I suspect this may be up your street. So how does it work? What's the study design? Are there toxicity concerns? Why do they do it in prostate cancer? What were the results? And what's happening next?
So this is a bispecific T-cell engaging antibody, but it's actually got 2 heads that look for the antigen, which is STEAP1, 6-transmembrane expressed antigen of prostate is the antigen. So 2 of those and 1 for CD3. So it's a little bit different than the 1-to-1, which most bispecifics are. So it's trying to get the T-cells into the tumor to attack. The study design is a phase 1 multiple dose exploration study. The main toxicity, in addition to cytokine release, I don't know how much this was talked about in the meeting, but there are these musculoskeletal events that happen, these sudden onset pains that can be bone or muscle, which was part of the dose-limiting toxicity. And the cytokine release was actually not that difficult to manage. And you moved away from the rest of the bullet points, but.
Oh, you're doing really well. You're doing really well. Toxicity concern. Why do
prostate
immune
cancer?
therapy in prostate cancer?
STEAP1 is very, very heavily expressed in prostate cancer. The efficacy results, there was at least greater than 50% had a PSA response of 50% or greater. There was also objective RECIST responses seen more so in the higher dose cohorts. This was hundreds of patients and multiple doses tested.
Fabulous. Anything from this side? I guess a bonus point would be, why would you pick prostate cancer, which is an immune desert, to launch a bispecific T-cell engager?
Because you're bringing the T-cell into the tumor.
Right, that's brilliant.
Basically what you're doing.
That's brilliant.
Lots of toxicity, well, not toxicity,
Yeah,
but
well,
then they had to pre-medicate with steroids to mitigate some of the tox.
What would you combine it with moving forwards?
So we combine it with drugs that work,
Or
which is like
drugs that require immune cells to be there.
For example,
Checkpoint inhibitors.
checkpoint inhibitors. Tanya, what else? What would you combine it with?
I think you need to heat up the tumor microenvironment to encourage the T cells to get in there. So I think there will be interest in things maybe radiation-based or other modulators of the tumor immune microenvironment.
Don't radiate those T cells as they swim into
Yes.
the tumor, though.
Yeah, and don't give chemo. I would say PD-1 is probably the most reasonable, but because it's also tolerated, but the toxicity rates here were not completely benign.
And the data with ipilimumab have been negative in this disease, but to Tanya's point, that may be a potential companion partner here to bring more,
But
relevant
basic
cells.
oncologic principles are not, yes, I understand we need to upregulate the tumor microenvironment, but basic oncologic principles are take 2 drugs that have demonstrated activity and as opposed to taking 2 drugs that have no activity and combining them together,
However,
that they're going to actually now work.
Dr. Agrawal will argue that contact 02 is positive, cabo-atezo, in the absence of individual benefit.
We haven't seen the data yet,
Right.
fully presented.
Press release.
But the phase 2 clearly showed efficacy,
Yeah.
and we know that cabozantinib modifies the tumor microenvironment in ways that then allow the immune cells that make it in there to do what they need to do. Depleting Tregs, having more dendritic cell infiltration, these things are important.
Very good point. Yes.
Shilpa, you should be in
Another
charge of.
question.
Shilpa, you should be in charge of points, or you could be the point fair person. Do you think 5 points here, and 3 here, or 2?
5?
5 and 2. Okay, we're going for the next question.
Okay.
Well, there's going to be clarification on the scoring. There's definitely been clarification on the scoring before tomorrow. So, here we go. This is the next question. This is a buzz around question again. When was the overall survival press release of the adjuvant pembrolizumab keynote 5/6?
It's your trial.
Yeah, here. When? We buzzed.
The adjuvant
It was
pembro press
Tuesday,
release.
right? Wasn't it Tuesday?
For overall survival,
For
was-
overall survival, it was Tuesday.
the exact date was...
What was Tuesday?
No, you can't look.
Can't
No,
look.
the
Can't
calendar,
look.
the calendar.
Can't look.
He's
Tuesday
just looking
of this
at
week.
his
It was
calendar.
Oh, what
Tuesday
date
this
was
week.
that? Tuesday this week.
This was
Halloween.
October 31st.
Halloween.
October 31st,
Halloween.
2023.
Halloween.
October 31st, 2023.
Okay, here we go. Petros.
All right.
We got the 564.
Put this here and just be sitting on it.
So keynote 564 is the adjuvant. Here is the data. This obviously isn't the data for the update. This is the previous data at the 30-month cut. We don't know anything from the press release. But the question is any positive trial with survival in this space meaningful? And do they subset, like the M1 NED and the high risk, would these influence your decisions? So, obviously, we don't know the results of the trial. None of you three know the results of the trial. You can confirm that. But in a speculative perspective, do you think that because it's OS, it's positive? Because in Europe, it's not. It's got a 1C recommendation, weak recommendation for. Do you think any survival signal changes practice? Number one. And number two is, do you think that we will look at the subset plots or the subset analyses and pick and choose the population because that works best?
This was already, influencing my practice. I unfortunately led one of the negative studies in this space with the atezolizumab, and there's been a lot of discussion as to whether or not we sort of lump in the 3 negative trials that we've seen so far alongside this one, include that as a consideration. Having said that, I see no reason to really contest this data. This is clear as day in terms of the DFS benefit. The OS has been trending in the right direction since Toni originally presented this data in a plenary session at ASCO. So, this immediately changed my practice. And I think that the OS advantage that we saw in the press release, congrats on that, by the way, guys, it's huge. I think it's huge, is just icing on the cake.
Rana, not Toni, but Rana, to you, what do you make of the fact that not all of the trials in this space have been positive? Could you name the trials that haven't been positive and maybe come up with an explanation why that might be the case?
Absolutely. So the other trials are Emotion 010, I believe, led by yours truly over here, Dr. Pal. That was a trial of atezolizumab. Atezolizumab has not demonstrated, it has demonstrated some activity from Emotion 150, but it does not have an indication alone. And that trial also did include some non-clear cell patients. Prosper was also in this space. Prosper is a very different study, was done through the cooperative groups with 1 dose of nivolumab pre-surgery, followed by subsequent 9 months of nivolumab. And there was a lot of opportunity where patients did not get the intent to treat, treatment on that trial. So very different. And there was the trial of Nivo-Ipi, and now it's not 901 because 901 just got presented.
914.
There you go. The assistance. But that was a trial of Nivo-Ipi. Nivo-Ipi given for 6 months with different dosing of the Ipi. The Ipi was dosed every 6 weeks, but there was significant toxicity. And I think the tolerance for toxicity in the adjuvant setting, as we've seen in other adjuvant studies, are different. So I don't equate this to like the sea of negative trials, the negative TKI trials with 1 positive, S-track study for just DFS with no OS and no quality of life benefit. I think this is a very different situation that we're in now with the adjuvant IO therapy. So I do think that this trial stands alone in its design, in the agents, in the dosing, and this is practice changing. I mean, we're all excited to see the OS data, but this is,
Toni, how many times have we seen overall survival signals in kidney cancer in the adjuvant setting before?
Since 1973, the first randomized study, many of you in the room, some here, were not born. Only David McDermott in this room was born. So 1973 randomized trial, none of them had overall survival. So Keynote 564 is the first positive adjuvant study in renal cell for OS. And I would venture to say is the first study in solid tumor or liquid tumor with a single agent PD-1 inhibitor that is positive. No studies in lung cancer, melanoma even has an OS after surgery. None. There is EFS. None. There is a neoadjuvant adjuvant, but that's not adjuvant. So it's big deal, and we look forward to seeing the data. I only want to add one thing to Rana, is that Matt and Jonathan debated ad nauseum carboplatin and cisplatin. If carboplatin and cisplatin were today, people would think of them as both PD-1 inhibitors. They're not. I'm not sure how different they are. I think here there is no other study of pembrolizumab that has been negative. These are, to me, different, completely different drugs, even if they work on the PD-1 axis. And that is probably the reason.
Thank you, Tony. Shilpa, what are we doing from a mark perspective? I think this team certainly has a 5, and this team a 2 or a 3. I think it's a 3, isn't it? 3 is better. Okay, so we're now into...
No,
it's a tie.
There's no way.
So here we've got 4 minutes and 22 seconds left.
What's this?
Okay, so who launched the war on cancer in 1950? Sorry, who launched the war on cancer 53 years ago?
President Nixon. President Nixon.
President Nixon did launch the war on cancer 53 years ago.
But
What's going on here?
So here we go. This is metastatic prostate cancer. These are 3 patients. These are their patients' characteristics. The one on the left, no prior docetaxel, no HRR alterations. The one in the middle, MSI high, HR alterations, no docetaxel. And the one on the right, no prior chemotherapy, HRR alterations. What you need to do is you need to pick the best treatment, and then the other team needs to question that. And if they can come up with a coherent argument as to why you've picked the wrong treatment, then they win, otherwise you folks win. So you have to get all 3 right, and if they can justify one treatment that they think you've got wrong, then they're going to win.
how's that fair?
So I would say...
You go first. It's like playing tennis. You're serving, Tony. You're serving.
This is a patient with first-line metastatic castration-resistant prostate cancer. They've already progressed on ADT on an ARSI, and they've got PSMA-positive disease. For the first bucket of no prior docetaxel, no HRR alteration, while we did see the PSMA-4 data get presented of the activity of lutetium prior to docetaxel, 80% of patients had crossover. I don't think we yet have data to say that you have to do lutetium prior to docetaxel. I think in that scenario of, I'd want to be thinking about other patient characteristics, but I'd probably favor docetaxel, understanding what the patient's,
So docetaxel on the left-hand side.
Probably for the no prior dosing, no HRR
on the left.
alteration.
What about the patient in the middle? MSI high, HRR alterations, no docetaxel.
So MSI high, HRR alterations, no DOSI, and they're PSMA PET positive. It's a tough one here because you may want to be wanting to select a PARP inhibitor, potentially with olaparib. I think in the context of PSMA-4, they tried to do testing and make sure that patients had received olaparib if they were eligible to receive olaparib. I would want to know the type of alteration. If it's BRCA1, BRCA2, sooner better. If it's some other thing like ATM, I probably wouldn't want to jump into that. I wouldn't do anything about the MSI high. The data is very poor about Pembro.
What are you going with?
Okay, so I have to pick one.
Yes.
PARP with Enza or PARP alone in that scenario?
And they're also no docetaxel. I mean,
Or just give dosing.
they've already seen Abby. There's only 50 patients from TALAPRO-2 that had received prior. I want more data, but I guess probably leaning towards PARP alone, but want more data.
PARP alone. And the third patient, no prior chemotherapy, HRR alterations.
Why do you guys not like chemotherapy? Nobody likes chemo. No prior chemo, HRR alteration, and they were all progressing on PARP. It's basically this. The MSI high again is like it's the same person. You could do enzaparp. You could do enzaparp for the first one too, or the middle one, number 2.
So the first one you got docetaxel. What's the middle patient?
Oh, wow.
The middle
The
patient
middle-
you said PARP and ENZA plus PARP, and the patient on the right?
Honestly, the enza plus PARP data is like just 50 patients. Like, why are we
Right,
can't
PARP
be
alone.
making decisions based off
You
of
don't
that?
have
like,
to. It's your choice.
Okay,
You've
PARP
only
and
got
PARP.
25 seconds.
PARP and PARP.
PARP and PARP. Tanya.
We have
All
a
right,
lot
so-
of edits.
I'm sure.
I think for the first patient, lutetium-177 PSMA is a great choice. PSMA-4 showed progression-free survival of 12 months, whereas post-chemo, it's closer to 8 months. So
Impressive hazard ratio, to your point.
we have a lot to still learn. There was an overall survival benefit because there was a
85%.
specific crossover provided in the trial. And patients tend to have fewer grade 3 toxicities on the radioligand therapy than on chemotherapy. There's no permanent neuropathy risk as there is with docetaxel. So I think the first patient we would use lutetium-177. The second patient, MSI-high Wasima Beta published. Pembrolizumab has about a 50% response rate in MCRPC. Granted, it was a small series. Our own institutional series, hopefully, will also become available. And we've had really tremendous success. We've had pathologic CRs in a patient who insisted on having his prostate removed after pembrolizumab for MCRPC with MSI-high. So I would definitely, for the second one, choose the pembrolizumab.
And to add to Tanya's fantastic points, many patients with MSI-high, which is the best biomarker in the world for IO alone across tumor types, we see many passenger mutations with HRR. So without the driving role of HR alteration in the context
So
of MSI-high.
completely different so far. What about the third one?
Greek food.
So the third one, I agree we need more information on the HRR alteration because there are huge differences. I mean, you know, whether we're talking BRCA1 or 2, then it's a slam dunk for PARP. If it's ATM, then I agree with Rana. PARP has much lower activity, so I think we're just not given enough.
So I think we're tied. So we're going to have to go to our final question because it's a draw so far.
gosh,
So this is a
okay.
buzzer question.
Okay.
Okay, and if you buzz in, you have to answer and get it right. Okay, here we go. So which US president has received immune checkpoint inhibitors?
Oh,
Jimmy
Carter.
Carter. We bust first.
Who buzzed? Who buzzed first?
No,
It was
here,
this team
here.
here. It was this team here. We're done.
All right.